Hi, everyone. Welcome to another edition of AJOG MFM, live at AJOG MFM. It's great today for me to have so many experts in the field. Let me introduce them since I'm so excited to talk about COVID acceptance in uh, uh, in pregnancy. Um, let me get the right view. So Heather Huddleston is an assistant professor at UCSF, and she'll talk first. Heather, hello.
Hi, can you hear me?
Yep. Smita Rawal, together with her mentor Rebecca Stone, will present the second study. Hi, Smita and Rebecca.
Hi.
I'm so excited to have Brenna Hughes from Duke, who's a national and international expert on vaccine in general, especially on COVID. Hi, Brenna.
Hey everyone, thanks for being here.
And we have two other panelists, Terry M. Bennett. She's actually our new AJOG MFM Equity, Diversity, and Inclusion editor from NYU. Hi, Terry. You're muted, but that's fine.
Good afternoon, everyone. It's lovely to be here today.
Thanks. And then, cherry on the cake here, really, Denise Jameson, the chair at Emory, worked many years at the CDC, as everybody knows, big-time expert on this topic. Hi, Denise.
Hi, so nice to be here. Thanks for the invitation.
So, as usual, we'll try to do some 3 or 4 quick presentations, and then we'll have a discussion. I'll ask everybody to mute themselves unless they're on. We do have a little bit of background noise. So since the beginning, the pandemic, as you know, began sometimes in February, March of 2020. And I felt this was a humongous importance. AJOG MFM was only 1 year old to attack it with lots of science. We knew very little. And I was incredibly surprised. I remember when I got this small meta-analysis, we're still talking about other coronaviruses, SARS, MERS. We only had a handful of cases of COVID-19. Eventually, this got 455 citations in New England, Lancet, etc. A very early study that I got, I think end of March or beginning of April. Mary Dalton called me. She said in New York, we began to have a lot of cases. I don't think anybody had other cases, but they had a lot of cases at Columbia. And together with them and others in New York and Philadelphia, we put some cases together, 438 citations as of today. Amazing landmark studies. We put together again with the New York people some early data on severe and critical cases, which, as you know, happen. Again, highly quoted study. Then we put together with one of our faculty here at Jefferson, some guidance, which we didn't know much about, which again was published after peer review quickly at AJOG MFM, and then we've been published highly cited vertical transmission papers. We really wanted to attack and give as much scientific information about COVID-19. And we early on got a lot of feedback, as you can read yourself in your slide. It was really about trying to save life, improve lives, help the many pregnant women who got COVID-19 before the vaccine was available, and very proud of those early days. We ended up, as of today, publishing at AJOG MFM, the Pink Journal, 91 studies on COVID in pregnancy, and 11 on especially the vaccine, which I thought was extremely important because, again, prevention is what I think medicine should be first and foremost about. So we'll talk about vaccine acceptance, and I wanted to put some kind of background information. We want to shoot for 100% with everything, but for example, for the flu, in the pink here is the US data, just published in a review article in the gray this month, about 60-some% for flu and about 55-60% for Tdap. And in the world, it's really very wide for flu and about 70% for Tdap, and some use just the tetanus shot. So The first two talks today from some of the most recent COVID vaccine in pregnancy data we have at EJOG-MFM. It's from UCSF and Heather Edelston. And then Smita will go over her systematic review. So with that, that was just quick background information. I will pass it on to Heather, share her slide, and Heather, you can take it from here. Thank you.
Okay, thanks so much. That was a really interesting introduction. So I'm going to just walk us through the paper that was published in this journal fairly recently. So as background, and I'm sure this audience is well aware, we know that pregnancy is a high-risk category for COVID infection, but that unfortunately pregnant women were not included in the trials for the vaccines. And that made the rollout a little bit bumpy and difficult, but ultimately very important bodies, including CDC and ACOG, issued supportive guidance, really encouraging vaccination through a shared decision-making model. The objective of this study was for us to determine sort of early on in the pandemic, what were the rates of vaccine acceptance and utilization in pregnancy, really during the first 6 months of the rollout. So kind of important to know that this was, I always think of COVID as very much a moving target. And this is really talking about attitudes of pregnant people, sort of April or March through the next 6 months. So to answer this question, we used the ASPIRE cohort, which is a cohort study that I'm involved in at UCSF. And this study design is, it was something that we launched right in the beginning of the pandemic, so essentially in April of 2020. Our goal was to recruit women in the very early parts of pregnancy, so less than 10 weeks gestation. I am a reproductive endocrinologist, and so this is a patient population that we see and talk to all the time. We wanted to recruit people very early in pregnancy, prospectively follow them throughout pregnancy. And the initial goal was to look at exposure to COVID, and we planned and used blood spot testing that the subjects did on their own and sent back to us, and surveys throughout pregnancy. And then the goal ultimately is to look at outcomes. In particular, we're interested in some childhood outcomes. As the vaccine was launched, we were really interested in also looking at vaccine exposure and non-exposure in this patient population. And so we instituted a monthly questionnaire that was sent out to all of our participants to query their thoughts on vaccine, whether they'd been vaccinated, and a variety of other topics. So in terms of the study inclusion, I'll sort of zeroing in on this sort of middle part of this chart. There were about 7,000 women who have been consented to participate in the ASPIRE study. This is a national cohort study. Most of these people have been recruited through internet-based advertising, a lot through Baby Center, actually, is the majority of our ways that subjects heard about us. In order to be included in this vaccine study, though, we looked for all of our subjects who had no confirmed vaccination prior to conception, which was about 6,000. They had to have submitted a vaccination form, one of those monthly surveys, at least since April. And then we looked at our community cohort, and what that is referring to is that we also have patients who were recruited through fertility clinics, but we felt that they were a different category. And so we only used people recruited through the community. Ultimately, we had about 1,000 non-vaccinated and 1,400 vaccinated participants. So this is showing that breakdown. So you can see 57% were vaccinated, 27% had no plan to vaccinate, and another 16% were not vaccinated but planning. Another thing I'll just point out in thinking about this, these findings, which I think these rates are relatively high, but remember that this is a patient population that chose to participate in a cohort study, and a cohort study that would require a fair amount of involvement, including blood spots. So there is some limits to the generalizability of these findings. In terms of the sort of breakdowners, we wanted to look at these participant characteristics by vaccination status. These are all the unadjusted data tables. And you can see that, I think as we might expect, from based on general population studies, race was a predictor of vaccination, with in particular African-American women being less likely to be vaccinated. Education was a very significant predictor, with more education tracking with likelihood of vaccination, as well as income. We also looked at work status, so people with full-time employment were more likely to be vaccinated. People who were unemployed or full-time homemakers were less likely. Interestingly, being employed in the healthcare field was not a predictor. There wasn't significant diversity across regions, although there was a little bit, and there was an increase in vaccination if you lived in a metropolitan area. Now here we got into some sort of attitudes. We looked at, and this was at baseline, so before, they may have been even thinking about vaccination. So when these subjects filled out their baseline questionnaires, less than 10 weeks gestation, those that expressed some concern around COVID-19, just about the impacts on pregnancy, the impacts on giving birth, were more likely to be vaccinated. As similarly, people who were worried about their loved ones being affected by COVID-19 were more likely to. So these were people that were sort of at least were buying into the idea that COVID could be something that was dangerous to their health, were more likely to be vaccinated. Interestingly, when we looked at generalized anxiety scores, there wasn't a significant difference here. So it wasn't just anxiety that was necessarily driving this, but it was more the sort of concern around the actual disease. And here's where we looked at provider advice, which ultimately I think was one of the most important messages or findings of our study. We looked at who, and this was, remember, fairly early in the rollout of the vaccination or vaccination program. So we saw that about when we asked, have you been counseled by your provider? A fair number said no. So there was about 1,000 who said no, and there was about 1,500 who said yes. The people who had been counseled by their provider were much more likely to be vaccinated. We then asked a little bit more about what that provider interaction involved. And you can see here that, and this is looking at sort of if they were vaccinated or not. So if no clear direction was given, they were still more likely to be vaccinated than unvaccinated. If you had discussed the pros and cons, it was even significantly more increased. But then if you were told not to vaccinate it, a very significant rate of unvaccination. And then similarly, if you were told to vaccinate, very high rates. So we looked at this in a model where we sort of threw all of these predictors in so we could get a sense of what was really driving things, because clearly there was going to be a lot of confounding. So the things that really jumped out, race continued to jump out. Education and income continued to jump out as significant predictors. Being concerned about COVID definitely jumped out. And then when we looked at this advice, whether or not to be vaccinated, advice by your provider, the referring group here was just no information given. So you just didn't get any information. You can see that even if there was no advice given, it was just brought up compared to not being spoken about, you are more likely to be vaccinated. And certainly if you are advised to be vaccinated. We then looked at predictors of vaccination acceptance. This was when we looked at people who had not been vaccinated yet or were planning on it or considering getting it. And sort of the same findings, again, with this very, actually not completely the same findings in terms of a lot of the demographic predictors, but again, the sort of awareness of concern around COVID-19, and then any kind of discussion by the provider. Here's a chart where we looked at cumulative vaccination rates over time, and the different colors are showing the type of information received from a provider. So yellow here is the no information provided. There just hasn't been a discussion of vaccination. But here blue is advised to vaccinate. Orange is no clear advice given. So again, higher than just no information. And then here's our not advised not to vaccinate. And then just sort of the last slide here is just, to look at why is, reasons for not wanting to get vaccinated. So this was only a question that was answered by people who were unvaccinated and not planning to be vaccinated. That amounted to 665 people at that time. Biggest reason was being unsure about the safety of the vaccine in pregnancy. And then, some other reasons that popped up were sort of just being worried about getting sick, not thinking it's good for them, not thinking they're at risk, thinking that they don't need it because they've already had infection, et cetera. So just to wrap up, I think, we saw vaccination status being associated with key demographic categories in this cohort. Vaccination and vaccine acceptance were really strongly associated with getting information from a provider. And I think what it was important was clearly when there was directive advice given, it was a strong predictor. But even when it was just brought up as a topic, seemed to be really important. I think the take home was that providers can play a really important role in educating our patients about the impact of COVID and vaccination, and from a public health standpoint. And just as a caveat, as I said, the generalizability of these findings is somewhat limited to the type of people that will participate in this type of trial, but we do still think that there's some important lessons to be learned. And that, I think, is the end of my slides, and we'll move on to the next one.
Thank you, Heather. That was fantastic, and be the change you want to see in the world. The provider, we can make a huge difference, and I think that will come up, more and more as we go forward. Let's go to the next presentations, and Smita, you can take it away, your systematic review. You're muted, Smita.
Hello and good evening, everyone. Thank you, Vince, for providing us with this wonderful opportunity to share our research. Rebecca and I are very excited to be here, and today I'm going to share our systematic review entitled COVID-19 Vaccination Among Pregnant People in the United States, recently published in AJOG MFM. As we all know that pregnant people are at increased risk of illness and dying from COVID-19. Vaccination presents an important strategy to prevent negative outcomes in this population. However, less is known about COVID-19 vaccination among pregnant people. So we set out to assess the landscape of COVID-19 vaccination during pregnancy. We conducted a systematic review with an objective of identifying the safety, immunogenicity, effectiveness, and acceptance of COVID-19 vaccination among pregnant people in the US. We used PubMed, Web of Science, and CINAHL for literature search, and included peer-reviewed empirical studies related to COVID-19 vaccines among pregnant people in the US. 32 observational studies were identified. 34% were related to vaccine safety, 31% were related to immunogenicity and effectiveness, and 34% were related to vaccine acceptance among pregnant people. As for vaccine safety, similar to general population, COVID-19 vaccine-related side effects in pregnant people included injection site pain, soreness, itching, and fatigue. Immune thrombocytopenia was reported by a case study, but it was resolved by the use of corticosteroids, and there were no other complications. Regarding pregnancy outcomes, there were no reports of placental injuries and stillbirths, and miscarriage rates after receiving COVID-19 vaccine range from about 6.5 to 14.1%, and these rates fall within the 11 to 16% range, which is the expected rate of miscarriages in general population. And pregnancy outcomes, including gestational hypertension, preeclampsia, and thromboembolism, were similar to unvaccinated pregnant people. Regarding neonatal outcomes, there were no reports of neonatal deaths, and neonatal outcomes, including preterm birth, congenital anomalies, a small size for gestational age, and neonatal ICU admission, were similar to unvaccinated pregnant people. Moving on to COVID-19 vaccine immunogenicity and effectiveness, antibody production was in pregnant people was similar to non-pregnant people. Here we can see that the difference in antibody production between pregnant and non-pregnant people was not significant. And interestingly, antibodies were also found in cord blood. So it's likely that COVID-19 vaccination during pregnancy may confer some immunity to neonates. In addition, highest level of maternal and cord antibody levels were achieved after receiving a full vaccination series and a booster dose. Regarding effectiveness, effectiveness of COVID-19 vaccination in pregnant people was highlighted by two studies. In one study, vaccination significantly reduced the risk of future COVID-19 infection among vaccinated people. About 1.4% of vaccinated pregnant people experienced COVID-19 infection compared to 11.3% who were unvaccinated. In another study, 0.4% of Pfizer vaccine recipients and 0.2% of Moderna vaccine recipients experienced breakthrough COVID-19 infection more than 14 days after the vaccine administration. Now about COVID-19 vaccine acceptance among pregnant people. The vaccine acceptance rate ranged from 3 to 65%. Prior to vaccine availability, pregnant people's vaccine acceptance was assessed by a hypothetical question. If a COVID-19 vaccine were to become available for pregnant people, how likely are you to receive the vaccine during your pregnancy? Between 41% and 65% of pregnant people were willing to receive the vaccine before COVID-19 vaccinations became available. And those who refused were concerned about side effects, lack of safety data among pregnant women, and concern for their fetus. I'd like to point out here that the study that reported 65% acceptance rate included respondents that belonged to high income and highly educated categories. And all these studies were done at the end of 2020 and the start of 2021. Now, after vaccine became available, the acceptance rates were even lower. A study that collected data in April, May of 2021 reported acceptance rate of 3%. And a CDC VST study that examined vaccine data from December 2020 until May 2021 reported acceptance rate of 16.3%. And there were other cross-sectional studies that reported acceptance rate of 35.7, 44.3, and 58.3 acceptance rate. The study that reported 40.3 acceptance rate included pregnant people who were healthcare workers. And this study showed that working in healthcare was not associated with vaccine acceptance. So compared to other studies here, the acceptance rate of 16.3% in the CDC study may be accurate because of the larger sample size of approximately 135,000 pregnant people. And the fact that CDC's VST data comprises of medical records, health insurance claims, and immunization registries, there is a low possibility of recall or social desirability biases that is inherent in studies that rely on self-reported vaccination. Furthermore, studies that examined factors related to vaccine acceptance found that pregnant people who belong to racial and ethnic minority groups like African American race and Hispanic ethnicity, younger age group, pregnant people who were between 18 and 35 years, who were less educated, had lower than college degree, and those who had refused influenza vaccine in the past season, and those pregnant people who had reported lack of provider counseling were less likely to accept COVID-19 vaccine. To sum up, peer-reviewed studies support COVID-19 vaccine safety and protective effects for pregnant people and their newborns. Currently, there is low acceptance of COVID-19 vaccination among pregnant people in the US, although the most recent reliable acceptance rate we have was from May 2021. Acceptance rates and pregnant people and background vaccination rates may have changed since that time. And so improving outreach to and engagement with healthcare providers and pregnant people would increase vaccine confidence and thus coverage of COVID-19 vaccine among pregnant people in the US. Therefore, targeted and tailored strategies are urgently needed to improve vaccine acceptance among pregnant people. especially those who are in the 18 to 35 years age range, and those who have lower than college degree, and those who belong to racial and ethnic minority groups. And in future, we need more studies that have robust study designs like randomized study design, longitudinal study design, and also more studies using various vaccine types and booster doses. We need more of those studies. The references, and here is the link to our systematic review. You can use the link or the QR code to read the full article. And that brings to the end. Now I'd like to hear your thoughts on COVID-19 vaccination acceptance among pregnant people. Thank you.
Thank you, Smita. Great presentation. Thank you, Rebecca, as well, your collaborator. I'm going to pass it on to the last presentation to Brenna Hughes. Brenna, as I introduce you, I want to show you this. You've been part of UpToDate, COVID efforts. This amazing data I just got today. UpToDate published the first thing on UpToDate. I think the first day they got 15,000 hits. It almost has 500,000 hits, that first article. And now there are 3, as you can see, that have tens of thousands of articles. So altogether, over 500,000, I can't believe the number, 500,000 people have looked at your contribution on COVID, kind of testifying how important, worldwide this issue has been and continues to be. So I'll pass it on to you. Feel free to share your slides and screen. It's a pleasure to have you here, Brenna. You're muted at this point.
Great. Yes. Thank you, Vincenzo. I was trying to do everything at once there. And thank you for having me. And also thank you for your contribution for UpToDate, since you did it all alone at first. I wanted to start by just showing the COVID data tracker on the CDC, just so that folks can see that there is this real time. There's actually been a lot of work by the CDC at trying to get data out to the public so that people can manipulate data and evaluate data on their own. So this is the COVID data tracker that is online. You can see here, you can actually download the data here. And we'll sort of talk about the reliability of the different forms of data. But you can see that in general, it looks like vaccine acceptance is going up. The darkest blue is the during pregnancy acceptance. And so you can see that there was a time when there was a surge, when there was an increased acceptance, and we're starting to tail off again, as you might sort of expect across the country. And to follow up the other two speakers, it is clearly true in the national CDC data. This green line is the rate of vaccine acceptance among Black patients. And you can see that is, there are significant disparities that persist in terms of vaccine acceptance and receipt, perhaps access as well as acceptance. And then this is a website, the data.cdc.gov, that folks can actually go on to and manipulate the data themselves, that I just wanted to be sure people were aware of. It has various information about dates of receipt, as well as race and ethnicity, what type of vaccination people had, as well as whether they were vaccinated prior to pregnancy, during pregnancy, or both, for example, if they had started their series before. And you can manipulate these data. I played around with it a bit today and got these rates. I couldn't reproduce it, I will admit, but I am not the most tech savvy. But you can look at the rates of vaccination, again, during, prior to, and you can look at it by month on this view. And then I wanted to also just share a bit about some data that the CDC also makes available through its VSD program. You can see that the rates are quite a bit higher in this group. This is thanks to Dr. Jameson for getting this information for me. We know that the VSD is a small group of hospitals that participate or health systems that participate, and it's a fairly highly insured group. But you can see here that the vaccination rates have been going up and are getting close to almost acceptable rates in this group, although this is clearly sort of a falsely elevated rate of vaccination compared to the general population. But I like the way that you can visualize this data, and I think it's interesting to play around with. And if you look at just pregnancy again from a year ago, you can see that we've really had some significant increases in vaccination. But as we've all clearly stated, there continues to be significant hesitation. This is just a small study that was done at Duke that was presented at the IDSOG conference. It was actually done by one of our medical students who is going into OBGYN. And she asked about people whether they were intended to uptake vaccine and if it was available to them, and less than half said that they would. And we asked them various survey questions around the health belief model, around perceived severity of the illness, susceptibility, benefits of the vaccine, barriers to getting the vaccine. This is an example. We looked at flu as well, but this is how it applies across any healthy behavior, really. And we also looked at whether they were likely to uptake vaccine related to their answers on the health belief model assessment. And essentially, it really aligned with what we see in other healthy behavior uptake. So people who think that they are not likely to get the illness are not as likely to get the vaccine. If they don't think the vaccine is going to help them, they're not going to get it. If there are barriers to getting it, they're not likely to get it. And if they don't think that they're going to get that sick from the illness, they're not likely to get the vaccine. And this was interesting to us, but what was even more interesting to us is we actually had thought that we would see that medical mistrust, perceived racism, and barriers to healthcare utilization would really drive our likelihood of uptake, as we saw that there were disparities in our population in terms of uptake. But interestingly, while our African American patients reported more medical mistrust and more perceived racism in their healthcare settings, it was not what impacted their likelihood of uptake of the vaccine. It was the health belief model information. So when we think about getting vaccine to people and addressing these barriers, that's really where we've decided to think about how we focus our approaches locally, because frankly, it was a bit surprising, those results to us. So I'm really interested to hear what others think of that as well. I'm going to go ahead and stop sharing so that we can talk more.
Thank you, Brenna. That is great. So now to the even more fun part, kind of discussion. I'm going to ask actually Terry, Denise, and Rebecca one at a time to kind of jump in, since they didn't present, and they have, I'm sure, a lot to say, a comment or whatever they want to contribute. Terry, do you want to start?
Yes, absolutely. Thank you each for those wonderful presentations. That was very informative and I think thought-provoking in a lot of different ways, especially how we ended with looking at how racism, the perception of mistrust and perception of racism in the interactions of our patients with doctors and other providers. I'm also surprised by those findings as well. Anecdotally, and if you look at sort of other papers that's been written, even in JAMA and on social media, it seems to definitely be a tremendous impact, particularly in the beginning of the pandemic. I think access was a huge issue, more so than focusing on all the other multiple factors, what we found in New York was that even when there were focused efforts to increase the vaccination rate in marginalized communities, there was still an access issue, whether that was the knowledge in the community that this was available, or the fact that the appointments were taken up by people who were not from the community that the outreach was for. And as we have now continued in this pandemic and at the top of 2022, we are still seeing these disparities within New York. And where we have focused our efforts really is not only on access and information, but also on trying to address some of the systemic issues around perception of discrimination and racism. When working with community workers, what we hear prominently is sort of looking at not only the pervasive mistrust in the healthcare system, but also looking for trusted messengers. And I think New York State has done a pretty good job at trying to make sure that the right information is out there so that whomever is talking to the patient is delivering accurate information. Because one thing I certainly agree with that I found in my patient population that the last study just proved is about the information that we're giving, but also who's giving the message. And so finding a trusted messenger, I think partnering with community members, and leaning not only on physicians, but also on our midwives, on our nurses, on our doulas who are actively participating in the care of pregnant people across our nation is going to be extremely impactful as we move forward with healthcare in general, but definitely when looking at COVID vaccination acceptance rates.
I think your work on the community is so important, Terry, because first, it was presented before, you need to talk about the vaccine, but sometimes it's not even, and be positive, and you can make a difference, our studies have shown. But it's clearly that somebody from your same community, somebody that also looks like you and you can trust, you used that beautiful term, trust, is going to accept, the vaccine more than if it's presented from somebody else who maybe that particular person doesn't trust. So we can certainly expand on that very important thing, because the disparity is seen in every study I have seen. Denise, do you want to make any comment yourself?
Sure. I mean, those were terrific presentations and great comments by Terry. I mean, I guess, it's frustrating working day in, day out, recommending vaccine and feeling like sometimes you're losing ground rather than gaining ground. And I guess what I took away was that each piece sort of provided some clues for me about how it might be more effective. Brenna's presentation on the VSD data really provided a glimpse about what's possible, right? I mean, at least in some specific select groups, you can get up to 80% vaccination rates, which is probably the coverage rates that we need for herd immunity and to really get this COVID under control once and for all. So sort of what's possible. And then I really appreciated Smita's comments on predictors, but one of the predictors I was interested in is that a predictor of low vaccination acceptance is declining flu vaccine, which makes sense, right? If you decline flu, you decline COVID. And what we've seen pretty consistently is higher Tdap acceptance and lower flu vaccine acceptance in our clinics. And it seems to be attributed to the fact that how we frame the message. Tdap is a vaccine that really nobody heard of. Nobody knows what it is. Many people don't know what it is. It's given primarily to protect your baby is how we counsel about it. Whereas flu is given to, primarily to protect mother from severe disease, even though we know that there's infant protection as well. So, it just makes me wonder, should we be doing more counseling with COVID around what we now know is some infant protection rather than maternal protection? And then I was really pleased to hear Heather's findings about just bringing it up makes a difference because with, increasing vaccine hesitancy among those who have chosen not to get vaccinated yet, it gets harder and harder. And it sort of made me realize that you shouldn't give up. You should keep trying. And even just bringing up the topic may have some effect. And then Terry's comments about the trusted messengers, also something I was very interested in. All the studies looking at flu vaccine acceptance all say that the most, the healthcare provider, the physician provider is the most effective person at counseling about flu vaccine. But I've often wondered the same thing. Did we really study it correctly? Do we really know that a physician, perhaps in a white coat, is the best person to deliver the message? Certainly in the place where I practice obstetrics, it sure seems like there are other people in the healthcare system that seem to be what you refer to as trusted messengers. And I don't know if there are studies looking at that, but it seems like something we should really consider.
Those are great comments. One thing that I just learned, Denise, it's I agree with you completely. We should frame it for the baby, because the woman would take anything, any problems, she would die for the baby. But if you frame something, I'm doing something for the baby, she often says yes. And in fact, my wife was pregnant not too long ago, and she goes their booster when she was, 30 weeks or something like that, because she wanted the antibodies for the baby, which otherwise the babies cannot be vaccinated and protected. So I think that's a beautiful trick, so to speak, to be able to be more effective. Rebecca, I don't know if you have other comments.
Yeah, what Denise and Terry said both really resonated with me. I think both about having a healthcare team and trusted messengers on those teams. So I've lived being the pharmacist offering the vaccine, both in a clinic setting before or after the physician visit and in the community pharmacy. And the patient goes, well, yeah, I'd like to talk to my doctor about it. And I think that even, I think like Heather mentioned, even just bringing it up and just touch point on it every time, and then having those other members of the healthcare team and other trusted messengers like Terry alluded to that may not be part of the healthcare team all kind of come together to help reinforce vaccine acceptance. So I think that that's really important. I very much respect the provider-patient relationship. I don't know if you guys know how powerful you are, but patients always say, well, let me check with my provider first. So I think even just a comment is extremely helpful.
Any other comments from anyone? Anybody wants to jump in and make some other comments?
I'll just sort of piggyback on what some of the others have said, which, as I think Heather mentioned, we really lost a good bit of time by the fact that we didn't have pregnant patients enrolled in trials to be able to give them the messaging early enough. And we now finally, over a year into this, have data that not only do antibodies pass, but infants are less likely to be hospitalized if their moms got COVID vaccine. And that's a really big splash, a really big message that probably we may not have embraced as much as we could as a healthcare community to really be sure that our patients hear that there's that benefit to not only themselves, but their infants.
That's a beautiful message, Brenna. I would say something controversial. I've said it in public before. I think it's unethical to still have randomized studies now. We should have done them 2 years ago. But do you think it's ethical right now to randomize somebody to a vaccine or not? I mean, I think I appreciate the effort, but it's too little, too late now. We have all this safety information, and your message about, again, protecting the baby, less hospitalization. It's wonderful. I have a general questions how we could better start having COVID vaccination be part of prenatal care more routinely. I don't know if ACOG or SMFM, you guys are part of it, or doing anything to be able to say that, in our EPIC chart or our EHR, it should be at the top of the list, a checkbox. You ask at the first visit, you ask during the pregnancy. How do you go about? There are questions about boosters. So I don't know if anybody wants to comment on how we can make it kind of more routine.
Well, one thing I wanted to jump in and say, and because I'm in REI, I'm not in taking care of pregnant patients as much later on in pregnancy, but one thing that struck me as the vaccine was initially rolled out was just that it was available at pharmacies, it was available at drive-up clinics, and I wondered if there was a better ability to really deliver it in the office, if it had been given to providers' offices, whether that would just have at least in light of what we're seeing about how important provider discussions are, if the vaccine had then been there and able to be administered more quickly, how much of a difference that might have made. And I know there's so many limitations to how, these vaccines work, but certainly in the pediatrician office, if your pediatrician brings up vaccination and your child is missing one, it's like right there, like it's happening really quickly. And I just would love to hear everyone's thoughts on that and in your settings.
I mean, I think we know from flu vaccine that I agree with you, having it in the office increases acceptance, having it right there. And I was telling somebody before the call that I got my second booster today, and I was not intending to get it today, but I got it. I was intending to get it, but I hadn't quite gotten around to it. But I had an annual visit with my physician, and she said, "Do you want to get it today?" And I said, "Sure. It's here in the office." And I said, "Sure, I'll get it." And so I think having it in the office makes a big difference. Then they said, "Oh, actually, we have it, but it just came from another site and it has to defrost for 15 minutes. So can you wait 15 minutes?" Which, of course, I didn't wait, but then I came back. So I think that highlights the issue about feasibility and logistics in the office, is that the COVID vaccines are just the mRNA vaccines are just logistically more difficult than flu vaccine. But I think we've got to figure that piece out and make it as easy as possible for our patients to get vaccinated and to say, yes, I'll get it right now.
And to Terry's point about getting vaccine into the community so that it can be delivered by trusted community members for those who may not accept as well in a provider office, if it's offered in your community by someone who you trust in like community events, we've seen great uptake in the community in those ways as well.
Terry, do you want to expand on community somewhat? And
I agree. I could recall sort of in the earlier parts of the pandemic and speaking with pregnant people in the clinic. And sometimes if I can get a pregnant person who's sort of on the edge, but they're worried that it's going to hurt their baby, et cetera, and they're not noticing the benefit. I loved what you said, Denise, about reframing it about helping your baby. And that's how I lead with my counseling. I was pregnant during the height of the pandemic in New York, and I received the COVID vaccine during pregnancy, which even for me, I was a physician, so I got offered the vaccine very early before really we had any data at all. And so it was definitely not an extremely easy position, want to include my family and my partner in that decision as well. But to be able to counsel patients and say, hey, I understand your worry. I hear your concerns. I had them too, but I think it was the best thing I ever did for my daughter. I protected her. It was the best decision I made. It was, I have no regrets and I've seen no harm, and she's healthy and she's beautiful and all the great things, I think was very reassuring. But then there was that obstacle of access again, because it wasn't in my clinic. So even if I met someone in that moment and they said, okay, yeah, I hear what you're saying, I'll get it, I couldn't just give them the injection that moment. So then I had to hope that they would follow through to the next step to get the vaccine. So certainly that's an area that we need to figure out how to improve nationwide. I think the other thing, the reason why I also mentioned community is because I do think the information, the message is important. But if we're delivering different messages in already a healthcare system that is plagued with mistrust, then that is a barrier that is almost, really difficult to overcome. And so I think when I say working with our community, it's also about making sure that we're delivering the same message, that we have the same information, that the most recent publications out of AJOG, MFM, et cetera, is also reaching the community. So they're armed with facts. So they're armed with data. So they're not, distributing information that may be old or outdated or based on he say, she say, but really like, here's the data, here's what it shows. If I'm saying that as their doctor and their doula is saying that and their midwife is saying that and their family, is reading this, that's how we're impactful. But if I'm saying something different than the doula or her cousin or her mother, now we have obstacles that are very difficult to overcome. So when I say community, working with our community, it's twofold. It's also allowing our community leaders to deliver this message accurately as well, and arming them with the data, and also arming them with the product of the vaccine to deliver within their communities as well. So I think it's a two-prong approach that is absolutely essential.
And I feel compelled to point out somewhat the obvious too, but I think that it's great to have the vaccine in the clinic, and that's the preferred method. But also, 1 out of every 4 pregnant women have taken a prescription med in the last 30 days, and 7 out of every 10 pregnant women take a prescription medication at some time during their pregnancy. So also, if logistically it's not feasible that day, saying, hey, when you go get this prescription filled, the pharmacy can give you your vaccination at that time too, and just plugging those other health and community resources when the immediate isn't available, I think can also be effective.
Absolutely, and they're all the pharmacists. I think it's so important. Smita and Rebecca is part of that larger community, and it needs to be approached from everywhere. I wonder if anybody. I get a lot of questions about booster dosing. I did get my 4th dose and 2nd booster last week, and there's a lot of questions. Should pregnant women get it, even based on they've been vaccinated maybe 4 months or 6 months or more? I know the CDC doesn't have any guidance yet. I wonder if you can make a comment on what's going on now and what you think the future will bring.
I'll start, and then I think Denise will be the more expert of us in this space. But I think we anticipate that as we see our next wave of disease, it may be that that people with risk factors, including pregnancy, will be recommended for the next set of boosters. I mean, we have certainly seen very clearly that our patients who are in the ICU or have died from COVID, unfortunately, during pregnancy, have all been unvaccinated. I don't think we've hospitalized or had in the ICU a single vaccinated person. So being sure that we keep people well vaccinated will be our challenge, I think, in the future, to be able to protect them.
And I just want to say that I think it was confusing the way it was rolled out in the press. I think it created a lot of confusion because you couldn't quite sort out whether pregnant persons were included in the second booster recommendation or not. It is people 50 and older. It's people 12 and older who are moderately or severely immunocompromised. And then it's this group of people 18 or older who got J&J. 2 doses of J&J are all eligible for a booster. And the reason why I think it was so confusing is there was some language about people 50 and older being eligible to receive a second booster at least 4 months. And then it said a second booster could benefit people as they are at increased risk for severe COVID, but they were talking about the 50 and older. They weren't talking about people at increased risk like pregnant persons. And that got all mixed up in the press. And so at least when I first read it, I thought it included pregnant persons. And then to answer the second part of your actual question, I agree with Brenna. I mean, I think it's just a matter of time before we're going to get more and more COVID vaccines. How often? Yeah. I don't know.
More to come. It's a moving target every day. So many articles come out, so much guidance, and it's all good. Again, we were discussing before the call. We're going back in Philadelphia to be masked, in restaurants and public places next week. So it's still with us, and I'm still glad we have more science coming from all the researchers and people watching us. And I hope the guidance, it's always based on the best data. we only have about 5 minutes left. One thing I wanted to bring up for the clinicians who are watching us is how we can actually better implement it. I'll make an example. I've been on service, and you walk into a room and you ask, are you vaccinated? And some people scream back, no, I don't want to be armed. And but maybe there's something going on, and you can revisit the next day. And some people you bring it up, and they actually want to be vaccinated. But my point is, you have to talk to them. So what I actually told the residents and students and fellows is, on the problem list, on the right side of our list, COVID, vaccine, yes, last, and if not, why not, etc. And we could do the same thing with our EPIC, chart, outpatients. I wonder if anybody can give more tips on how kind of have continuous reminders, outpatient visits, inpatient visits about the vaccine.
I can start. One thing that that we have done with our EPIC system is on the left-hand side, where it gives you sort of a quick snapshot of that patient, is their COVID vaccine status. And if they're due for a booster, it also highlights in red. So it immediately lets you know, it's pretty much right below the names, if this is someone who you should be readdressing this with because they're due for their booster. So I think just those sort of gentle reminders across the health systems are extremely important, so that you can see right up front that this patient is due and needs to be recounseled.
Yeah, and we do similar to what you're describing, Vincenzo, with it's on our list in the postpartum list. It's built into our dot phrases for prenatal visits and our postpartums. And it's been, we spend, well, certainly Denise and I spend all our time thinking about this. And sometimes you forget that the rest of the world is actually just going on with their lives. And I've been surprised at how many people I bring up COVID vaccine to who say, oh, is it okay? Can I get that during pregnancy? And they really just didn't know. It's not that they've made a strong decision that they're not going to get it. It's just that it hadn't really spent a lot of time thinking about it because they're busy running their lives and weren't sure that it was safe in pregnancy. And sometimes that's really all it takes is, as you said, just talking to people about it.
Yeah, very important message. This was great. We're on top of the hours. Really, I think many important messages, and maybe the most important one, how as providers we can make a huge difference. By at every visit, every encounter, talking about it. If you're again a nurse, an MA, a pharmacist, a midwife, a physician, anyone. Any last comments from anyone to kind of wrap it up? If not, let me thank again Smita, and thank you again for publishing with us. Denise, whatever you do, I always try to read it and your guidance around. Terry, again, welcome to AJOGM FM. Thank you for being our inclusion specialist. So important. Looking forward to have you many times. Rebecca, again, great to have your pharmacist point of view. Heather, I didn't even know you were an RAI. I have a great paper, and thank you for giving us that perspective. And Brenna, again, thank you for you and all here have worked night and day on this issue and continue to do so. And I think have truly saved lives, because that's what it's all about. I look forward to many of you to join us for the next live at AJOGM FM. The next one will be on the use of ultrasound in labor. There was a special issue by Dr. Gee and his colleagues. Will be on April 19th at 8 a.m. Eastern. Many actually are going to speak from Europe, and that's why we're doing it early in the morning. So it's afternoon in Europe. And then we have a special issue by our Canadian friends on twins, and they're going to do that at 3 p.m. Eastern on April 26th. So thanks again to our panelists today, and thanks for everyone for listening. Stay safe and stay healthy, I guess. And then save pregnant women. Keep them healthy. Bye, everyone.
Thank you. It was a wonderful experience. Thank you, everyone.
Thank you.